Welcome back, everyone, to the Cooper COVID update. This is edition number 2. Today is May 8th, 2020. The purpose of this update is for us at Cooper to tell you what we are doing here so that those of you that are in the middle of your wave of patients or those that are gearing up for it are ready to take care of those patients in the best way possible. And this is just our local expertise. This is an educational program. This is not meant for medical advice, but we hope that this helps you in your practice. Today, I want to welcome back Jason Bartock and Nitin Puri, and welcome back a new face to the program, and that's Dr. Raquel Nahra, who's one of our ID specialists as well as our intensivists. So thanks for being here. So we're going to start off with you, Raquel, and we're going to ask you what drugs should we be using in COVID? What drugs shouldn't we be using? It seems like at first there were so many possibilities, and now there seems like there's almost nothing. But this literature is changing day by day. So can you give us an idea mostly about some of the antivirals, anti-inflammatories? I know there's a lot of vitamin C and steroids going around. Can you give us an idea of what we should be doing today, May 8th?
Hi, everyone. So those are very controversial topics, and we don't have a lot, not controversial, we don't have a lot of data to support one way or the other. Those are mostly, for now, at this point in time, based on retrospective, or definitely not all of the drugs we're using are randomized control, based on randomized control trial. So I will start with what I think we have that might be beneficial, and I will start with Remdesivir. Recently, the FDA released Remdesivir to be used under the emergency pathway, which means it didn't go through the rigorous process for being approved for the disease because of the pandemic situation we are in. So Remdesivir is a nucleotide analog, and it's an antiviral that was initially designed to treat Ebola virus. When it is approved now it's been approved under emergency use by the FDA. What emergency use means is that it didn't go through the rigorous trials that they have to go through before it gets approved by the FDA. Having said that, it's the only drug that we have right now that is an antiviral and has been studied in a randomized controlled trial fashion for use. I want to bring up that the most recent study published on Remdesivir looked at decreased days of symptoms, and that is similar to what you have seen studied for the influenza. When influenza, Tamiflu or oseltamivir was studied and approved for influenza, it didn't look at decreased mortality. It looked at decreased duration of symptoms and going back to the workforce. And it's the same principle with Remdesivir. So it showed there was a decrease in in the number of days that patients were symptomatic with COVID-19. It has some contraindication in the sense like if the patient has abnormal liver function, they tell you to not use it. The carrier for the drug is cyclodextrin, and cyclodextrin can accumulate in renal failure. It's the same carrier that you have for voriconazole, for instance, and it can accumulate in renal failure. So it's in renal failure patients with a GFR of less than 30, it's advised not to use. Because it has been approved under EAU, the emergency use, it means that the government, the federal government, is working like your distributor, your pharmacy distributor. So you have to show acuity, you have to show how you're going to use the drug before you can get access to the drug. So you can see, if you look at the Remdesivir website page, they give you a map of the US, and it tells you where exactly in the US the drug has been distributed, and you can see that that's focused in New York, North Jersey, and you have some sites like in Alabama, I think it was Tennessee, and then in the West Coast in LA. So this is in a nutshell regarding Remdesivir. The other drug I would like to touch on would be the IL-6 pathway inhibitors drug, and those are mainly tocilizumab. Um, the drug is used for rheumatological disease, and it helps with the cytokine release that you see with COVID-19. Again, most of the studies I've seen is like retrospective, telling you what they saw, and observational. I read a pre-published, non-peer-reviewed French trial where they had it was randomized controlled, and what they saw a 14-day decrease in mortality. They did not comment on increased infections with that or anything of that sort. Um, Another similar one that has interleukin-6 pathway effect is the sarilubimab, and this one has not shown much benefit. I have to mention it's a sub-Q dose medication, so I'm not surprised it might not pan out the same way because of all the pharmacokinetics that involves giving sub-Q medication on a patient who's critically ill. And those are the two main ones, I think. I'm not going to discuss hydroxychloroquine. I think people know about that, and I don't see a benefit on talking about that. Just in very short period of time, there have been talks about vitamin C usage. There is a nice review in the literature that looks at different use of dietary supplements in helping COVID. The way I can see vitamin C helping, it does boost your immune system, and that might play a role in helping fight the infection. We know from, I think it was 2017, where we had vitamin C used for sepsis and then had shown some benefit in ARDS. The only thing I would caution, vitamin C is a water-soluble molecule. So if the patient's renal function is normal, there is no harm you can cause by using vitamin C. It's really the patient whose renal function is abnormal and it cannot excrete the drug or the molecule that you can start running into problems. I think we need more data to see how it will pan out helping fighting COVID. For other viruses, for instance, herpes viruses, vitamin C interfere with the virus entering the cells, and that is a way that it can help prevent, for instance, outbreaks of herpes relapse, just by the mechanism by which it acts. I don't think we have this kind of data yet for COVID. The next topic that I've been very interested in is the use of steroids. Steroids seems to be the never-ending story. It always cycles. It always has, for ARDS or even other disease processes, we see that steroids is always brought up back to the table as the wonder drug that will help us manage patients. And I think it has its role more in the late phase of the disease when you're treating the late ARDS versus in the beginning, in the early phases of the disease. It might be harmful in the early phases in the sense where you have more viral shedding with it, and it can affect your ability to fight the infection. However, as for any ARDS, when we use steroids in the late part of it, it might have some benefits. And with this, Haney, I'll open up for discussion to the group.
Yeah, before I let you go, I did want to ask about the issue of convalescent serum or plasma, which is very popular now. But based on your read of the literature, how do you feel about that?
So I'm very conflicted with convalescent plasma. I mean, we always turn back to convalescent plasma in desperate times. So they used that for the Spanish flu in 1918, where we didn't have any drugs. And when we had the outbreak of Ebola, for instance, this was one of the ways that we managed to treat some of the patients. I think the literature needs to show us where we are. It is, I think maybe like everything we're doing for COVID, if you use it early on in the course, it might have a role. If you start using when you're making your own IgG, and sometimes if you give immunoglobulins and the one you're making is higher than the one you're getting, I don't see much of the benefit. So I
Okay.
think it has to take into context.
Gotcha. Well, thanks for that. Gentlemen, anything else to add to that or any questions?
No, I usually go to Raquel for all of my drug therapy. No, I mean, I haven't really had an opportunity to test, Remdesivir in our own practice. I think we had one patient who qualified, and that's because he was a pediatric patient at the time. He did well, but there were a lot of things that went into to his clinical course, so it's hard to tease out, whether remdesivir would be beneficial. But it has been the one drug that everyone's been talking about since the very beginning of the outbreak, as being the one that probably has the broadest effect. I think Raquel brings up a great point about convalescent plasma. I feel like for most of our patients, they're getting it quite late in their disease course. And I think, with the availability of testing both qualitative and quantitative antibodies, we'll probably have a better idea of how many patients already had antibodies produced prior to getting convalescent plasma, and whether or not, it worked. It's the magic that it's sort of, being hailed as in the media, because we're all looking for hope, but we also want to make sure that we do no harm. And I think, like a lot of things, a lot of these therapeutic targets make sense. It's just the big question is, well, when do they make the most sense, and are we missing those windows? I don't know.
Yeah, I've had a lot of concern about the drug therapy, because it's not been clear to me that it's helpful, and it's not been clear to anybody. And the IDSA guidelines came out and said you could use drug therapy, but they should be involved in a clinical trial. And from what I understand, although UPMC hasn't been hit badly, they were enrolling people in a 4x4 clinical trial where you got something. Every patient got something, whether it's convalescent plasma, remdesivir, hydroxychloroquine, azithromycin. And I feel like that model was really, really intelligent. But just giving medications and not being in a clinical trial, it's concerning. And I think that good supportive critical care is what works.
Yeah, this is coming up a lot as to whether or not we should focus on regular times, as normally we would do when we have a new disease or some challenge. We go through a clinical trial, we wait a certain number of months to elapse and do the right thing, or is this a special circumstance where this is really a wartime, to give it that terminology, and maybe we have to go outside the bounds of what we normally do, because face it, thousands are dying, and we have no treatment in sight. So perhaps we bend the rules a little bit because this is a special situation. I'm not saying that there's a right answer, but this is the conflict that I see amongst us as clinicians and scientists in this right now. Great. So let me turn it over now to Nitin, and let's shift gears and let's talk about some of the administrative challenges that have been going on. This pandemic has changed the way many hospitals function, the way that they see patient care and patient flow, and changed the practices that normal clinicians normally do. And I'm leading you into this, but could you tell us how Cooper Hospital has changed and adapted to meet the increasing demands of COVID?
We haven't really had any problems at all. So
okay.
It's been,
Jason, let's move on to
this is just, we used to say that, it's a pandemic, but it's just Tuesday night for Cooper Critical Care. In reality, both Jason and Raquel have played a heavy role in the way we've adapted. One of the issues has been staffing. We have, thank God we're not hit the same way New York City got hit or Northern Jersey, but we've been very busy. And so we've needed additional staffing. We've recruited colleagues from anesthesia and emergency medicine and some of our surgical colleagues. They've helped us. We've tried to titrate the patients that they've been helping see for us as people that they may feel more comfortable with us serving as a super consultant. There's a pretty famous slide from the Society of Critical Care Medicine where there's one intensivist for, I think, 60 patients, and the second best capable provider for the critically ill is our advanced practice providers. What we've done is tried to have one intensivist for 15 patients. And I remember speaking to Mangla Narisman from Long Island Jewish, and she was saying that one intensivist for 10 patients. I said, Mangla, how are you doing that? Or why are you doing that? And she goes, because the patients are so intensive. They require so much work. And at the time, they were about 10 days ahead of us and didn't understand what she was talking about. But when the pandemic came to us, we totally got it. So our ER colleagues have been doing consults for us. There's an intensivist available to go through the patient and staff them with them. Our trauma critical care colleagues have been seeing the non-COVID patients. And then critical care has been seeing the COVID patients along with our anesthesia colleagues. And, we're always available to review the patients, go through patient care. We defer the illest patients to come on to our service. Raquel had a lot to do with the design of having a COVID building and a non-COVID building. And then, trying to rule patients in and out and the way we do that. So from staffing point of view, that's what it's looked like. We provide 24/7 coverage. Our fellows have gone to a 5-day on, 5-day off schedule, which I know somewhere in Jason's heart has got to hurt. But they've been unbelievable. We have a total of 15 fellows, the critical care and pulmonary critical care fellows, and then the 3 trauma fellows have been helping out quite a bit too.
Just let me ask you, have the other services pushed back, or have they been volunteering very easily? Does this come from the top? For hospitals that might have trouble getting other services to come and be intensivists, or as you said, consultants with super consultants on top, what is a good strategy for people to get these other services involved if they're reluctant to?
Yeah, that's great. I will tell you, we have very good leadership here. We're very, very lucky. So the people who are in charge of these services supported us, and they recognized that the pandemic was coming. I think the most important thing is the hospital leadership needs to speak to hospitals that have gone through it already. The New York Times had a very nice graph yesterday saying that it looks like the number of cases are going down in the United States, but that's because New York is tanked, right? The number of cases are not, but there are small hotspots all around the United States. I think those people at those hospitals, the most informative thing you can do is speak to people who've gone through it. And what they'll realize is the ER faculty can handle the initial part of resuscitation. So going to a floor, going to a rapid response. Sometimes it's like seeing a new consult. They need to get emergency privileges. You need to do that stuff before, right? The anesthesia colleagues, they're used to taking care of people, putting, ET tubes, managing patients for a distinct amount of period. And anytime they're outside their comfort zone, then they refer to us as intensivists. But my number one suggestion is to speak to people who've gone through it, and they can help build the staffing model. And like I said, we had tremendous leadership from the top, Francisca Job and Dr. Cooper Smith, our colleagues, Dr. Schwalm.
Yeah, the other thing that's been successful that I think is worth mentioning is how you create backup systems and contingencies in place for when the services get busy or if providers get sick and they have to call out. How many layers of backup have you found successful during this pandemic?
Yeah, we staff 5 hospitals around the southern New Jersey region, and we've had a total of 3 doctors to provide backup. So we've gone 3 deep, and that's important because healthcare-associated infection, also pandemics are an extraordinarily stressful time. People might have other things going on. Also, there might be reasons why certain people can't work at different times. So backup 3 deep is good if you have a practice that's able to do that. Sometimes people aren't able to do that. The other thing, Haney, that made a big difference for us is our proning team. That was a really big deal. We, as we discussed last time, we went all in on proning, and the proning team, ours will, from I think 9 a.m. till 3, will prone patients. Sometimes they might prone 24 patients in a shift, and either prone or supinate, and that really was streamlined. But again, that was understanding how to repurpose CRNAs who weren't busy in the OR, anesthesiologists weren't busy in the OR, physical therapists, and EMTs. So it's just this amazing group of people to work together in a multidisciplinary manner. That's also, like, I gotta give a lot of credit. Cooper does that well.
Yeah, completely agree. I mean, when you hear the phrase "it takes a village," in this case, it really has. Everyone's come together. Everyone's gone out of their boundaries. And from what I hear, I mean, you're more closer to the top and you probably hear more of the grumblings, but I really haven't seen people complaining. It just seems like everyone's contributing. The residents are putting their work in. Everyone's just getting it done with a common goal. So it's been remarkable here at Cooper, and it comes from the top. It comes from the leaders. It's leadership by example, but it's been truly one of the things I've been most impressed with here.
Yeah, I gotta be remiss without saying 2 or 3 things. Our house staff, they just put Cooper on their back, and they're carrying us through this crisis. And it's not that we've been abusing them or anything like that. They're on 5 on, 5 off. The teaching from critical care has gotten very good reviews, in large part because of Jason and the amount of educational work he's done. I also will say that as I got tired, Haney, you volunteered for me. Adam Green volunteered for me. Bobby Cole volunteered for me. So we've looked out for each other, and that's the sign of a good group, strong group.
Definitely. Great. Do you folks have anything else that you want to add to that?
Yeah, I think Nitin never takes credit for any of it, but just the inertia to get something like this moving, I can't even imagine what it's like behind closed doors. Like you said, it's been very seamless. Like, people who have been working, who are working well outside the scope of their normal practice, don't seem bothered by it. The house staff all seem very, excited and engaged. And I know that it probably didn't start out that way. So, I just think hats off to Nitin and what he's been able to do over the last couple of months, because it sort of feels like the new normal. And, especially feeling, the stress of COVID early, I think that some of that has gotten a lot better. I mean, and I feel like most of us feel much more rested now. And then, and I don't know how it would work in a lot of other hospitals. I do think that there's something special about the way we do critical care, because we don't silo our critical care. So you sort of have one group managing critical care, and the way that, resources are divided. I think if you had one person managing a neuro ICU, one person managing a medical ICU, a trauma ICU, that could probably be more difficult. I would definitely suggest that someone just takes point and divides critical care services evenly.
Yeah, excellent point. It's Cooper has been always a very, very busy place to work in a very good way. You just always feel like you're getting stuff done. But it's interesting during this whole time, because of the division of labor and the way people are working, it almost seems maybe a little bit smoother and less busy than it normally is. But things will go back to normal in short time, so I'm not worried about that. Jason, let's talk a little bit, as the last part of this, we're going to talk a little bit about some inflammatory markers. And I think, you spoke last week about anticoagulation, and there's some updates, some recent literature that's come out. So I'll turn it over.
Yeah. So we went live with our clinical considerations for for both venothrombosis prophylaxis and high intensity anticoagulation in our COVID patients. We kept it pretty clear about both BMI and weight-based VT prophylaxis, and then using high intensity anticoagulation when clinically appropriate, and sort of stayed away from the half dosing. You sort of had to commit one way or another. So far, we've done pretty well. I think a lot of these patients have, with severe disease, have ruled in for systemic anticoagulation. And so far, knock on wood, we haven't had any major bleeding events, but we've been doing a pretty good job risk stratifying bleeding risk. There's some data coming out pre-published in JAMA about benefit for systemic anticoagulation in this population. And I think that it mirrors a lot of our early understanding and our continued understanding of the pathophysiology. And I'll use it as a segue for biomarkers. These are clinical syndromes. I mean, they're a constellation of symptoms, and nothing is 100% sensitive or specific for COVID in any one patient. So that's why biomarkers may be helpful, but shouldn't be used universally. And I've been able. We were able to use a lot of the protocols that were made around the country for considerations for anticoagulation. Many of them, had a D-dimer cutoff for consideration. We left the D-dimer cutoff out of our protocol, simply because not every patient who develops micro or macrovascular clot are going to have an elevated D-dimer. And we've actually seen that in practice. We just had a patient with clot in transit with a normal D-dimer. So, I think that, biomarkers, and this is sort of the segue, are helpful, as long as they sort of mirror the clinical picture. We can't use them to necessarily guide our therapy or our risk stratification 100%. I mean, whether it's, foreign antigen, from bacteria or virus, or, something autologous in the setting of autoimmune disease, hyperinflammatory syndromes in ARDS are not a new concept, and the cytokine release syndrome, going all the way back to the early 90s when it was coined, and the sort of T-cell hyperstimulation that went along with it, and this secondary HLH-like syndrome is also not a new concept, as it contributes to acute lung injury. And the secondary HLH has been associated with a number of viruses. We see it in EBV and influenza, and I'm sure Raquel can speak more to that. But, I think more importantly, we saw it in, MERS coronavirus, and I think was utilized, using inflammatory biomarkers. And what I mean by that is things like HLH, CRP, ferritin level, looking at triglycerides, fibrinogen levels, and so forth. And everyone's doing that, or at least most people are doing that nationally, and even looking at IL-6 concentrations if capable. I think that, China used it early, and then the rest of the world adopted it. I also see a lot of fatigue on rounds when it comes to these inflammatory biomarkers. And the questions that come up regularly is, so I'm ordering these every 2 days, what are we doing with this? And, as we run into sort of this lab fatigue and question whether or not it's actually playing into our practice, you have to ask yourself 3 questions, okay, when it comes to inflammatory biomarkers. Does it help with risk stratification? Does it help with prognostication? And does it guide drug therapy, right? And that's what I tell the residents and fellows. So in terms of risk stratification, my favorite thing to say in COVID is I don't know, right? But if you look at certainly the early data out of China, patients with higher inflammatory biomarkers tended to fall into the severe and critical illness population. So again, I think that elevated inflammatory biomarkers give you insight into a cytokine mediated dysregulation and the potential for injury. Trending them over time, there's no cutoff that any of us use to put somebody in the ICU versus a step down versus on the floor. But certainly, patients with high biomarkers you would be concerned for progression of disease. And I think we'll probably have more data soon. You know, I also think about it in terms of, you know, state of inflammation, just like you would if, you know, and this mirrors, you know, the rheumatologic data on, you know, patients with rheumatologic diseases, higher levels of inflammatory markers. They tend to do worse when it comes to like extra articular manifestations in RA or lupus or something like that. So, you know, when you think about the pro-inflammatory state in terms of prognostication, those are the people that, you know, maybe on CPAP on the floor and working to breathe. And then when you think about the population of people who are at higher risk for, you know, inflamed lungs, you know, increased work or breathing and self-inflicted lung injury, okay, I pay attention to them a little bit more. So answer to question one is, does it help with risk stratification? I think it does a little bit. Okay. In terms of prognostication, I think it remains unclear for me. You know, if your inflammatory markers are not going down, but you're extubated and you're playing on your iPhone, does that mean that I keep you in the ICU? No. You know, if they're not going down, does that mean that you're at risk for some sort of badness a week from now? I don't know. If, you know, but if everything is paralleling each other, then I think it makes sense. And that's just, you know, I mean, that's obvious. So I don't know about prognostication for mortality overall with trending inflammatory biomarkers. Like I said, I think it's helpful up front. I think it's helpful to think about in terms of response to therapy. But if it's not mirroring the clinical picture, I don't know that it's completely clear for prognostication. For drug therapy, I think that we have to be responsible when we consider using immunomodulators, that there has to be some sort of evidence that the patient has, you know, an unregulated immune system, or, you know, or this cytokine release like syndrome. So it's part of our algorithm for considerations for things like IL-6 inhibitors or the use of convalescent plasma. And, you know, and talking with people sort of in the region, I think it's also probably responsible to have it worked into that pathway so you don't take the shotgun of approach of giving someone both steroids and IL-6 inhibitors and convalescent plasma, because then we're never going to know if any of this stuff works, right? So I think, you know, when it comes to that, you know, I think it is helpful for risk stratification. I'm not really clear that it's helpful for overall prognostication. I do think it helps, you know, in being responsible for selecting drug therapy, trending it over time, you know, for considerations for redosing. I don't know when these things are supposed to go down. So, I mean, if you're going to do, you know, 2 to 3 doses of an IL-6 inhibitor, I honestly have no idea if I expect it to go down before the second or the third dose, but okay, I'm going to check it anyway. And, you know, and I do think anytime you get a lab, you should be talking about it. And if you're getting a lab and you're not talking about it, and it's not playing into the way that you're planning to treat the patient, I think it's not useful at all. So just to go back, I do think it's helpful for risk stratification. Prognostication is sort of unclear for me, and for targeting therapy, both drug therapy and I think the way that we use non-invasive and invasive mechanical ventilation. I don't want to harp on that too much because we talked about it last time. I think it may be helpful from that standpoint when you're really looking for patients at risk for developing worsening inflammatory lung disease. And the last part, which is why I still check it, is because just like Raquel sort of keyed into, is there a window for steroid therapy? And we've been very restrictive in our use of steroid therapy, especially when we have these regional conference calls with other local hospitals. And I think, you know, and that sort of mirrors, you know, the early MERS and SARS data, worrying about signal of harm and lack of viral clearance. We've been restrictive in our use of steroids up front. But like a lot of, you know, cytokine mediated inflammatory lung injury, you know, and ARDS, whether you look back at the early Lazarus trial data or the work that Maduri did, there's always been this understanding. And even if you look at sepsis in general and, sort of SIRS and dysregulated response to endotoxin, there's the antigen gets removed, and then you have continued inflammatory mediated disease absent whatever that is. So, in that population of what we sort of consider either refractory or persistent ARDS, it's really interesting because I've never done it before, but when you look at these inflammatory biomarkers and they remain high or they continue to trend in the wrong direction, despite the patient receiving sort of a full treatment course of whatever your COVID cocktail is, that may be the window for sort of responsible steroid use in COVID. Again, I'm making this stuff up, so I have nothing to back that up other than if I'm going to use it, if I'm going to use steroids, that's the population I'm treating, and I'm not treating coronavirus, I'm treating ARDS, as sort of outlined by the Lazarus data, the Maduri data, and even some of the new dexamethasone data. So that's where I find biomarkers helpful. That's all I have to say about that.
If you were to use steroids, what doses are you using, and how long, or is it just kind of feel it out, wait to see how the biomarkers are reacting?
Yeah, great question. So great question. So
you can make it up here.
Yeah, no, I'm going to treat for sort of persistent or refractory ARDS. So I would choose a treatment pathway, either that methylprednisolone, 1 milligram per kilogram, or go with the dexamethasone data. I still sort of believe that you have better bioavailability of methylprednisolone at the level of the alveolus. So I've always treated with methylprednisolone. So I would probably start with 1 milligram per kilogram bolus and then 1 milligram per kilogram per day for 14 days and see if they have improvement in their ARDS physiology.
Great. And then the other question I was going to ask you, and then I'll open up to everybody, is do you ever feel the need to collect the biomarkers just because we're in a time where we're collecting data? Maybe 3 months from now, it would be helpful to look back at some of the data that we collected, where it didn't change what we did. It might change how we look at the prognosis. But even if there's nothing done based on that data, it helps us to collect something that we can look at retrospectively and figure things out, because I hope that we're not in the same place that we are 3 months from now, but 3 months from now we might be, and that data might be helpful to help make some clinical decisions.
Yeah, I'd like to hear what Raquel has to think. I'm interested in pulling the IL-6 concentrations in the patients that we're treating, because I think the turnaround time is a little bit better than it was even a couple of months ago. And I also wonder if the next time I treat ARDS that's non-COVID, am I going to order these biomarkers? And I'm sort of programmed at this point. So I'm not really sure. That's why I do think that we really need to tease out what's beneficial and what's just part of this clinical syndrome that we've always known was happening, and is if having a level is really helpful in the way that we manage.
Gotcha. I'm going to open it up. I'm going to unmute everybody. Let's just open it up and hear everyone else's thoughts on this.
All right. I always liked steroids in ARDS, and I think there is a role in a specific population. I'm a big fan of Dr. Maduri's studies and the way he conducted them, and the fact that he was going out there and doing biopsies and doing cultures on the lung before initiating the steroids. I think you hit right where the money is, Jason, that I do believe the biomarkers play a role. And I really think that once your acute phase of the viral infection is over, there is a role for steroids. I just don't think the role is in the beginning. And looking at some of the CDC released data and more recent data regarding of the viability of the virus. So some recent data showed that after 10 days of acute illness, they were not able to culture the virus. And that tells you, right, what you're saying, that all that you're seeing post day 10 is probably your own immune system reacting. And that's why in the past, for instance, for influenza, or for the Spanish flu in 1918 that convalescent plasma worked, or that could explain those kind of findings. So um, I think the steroids are a good idea later on for ARDS treatment. And I would even argue, should we be doing the long course like Meduri did in his initial trial, and that the category of people who improved with the steroids are exactly the category of people that you see in COVID, even though he didn't have COVID right there back then, but are the people who had some leukocytosis, had some fever, persistent, not explained by an infectious process. Again, I have no data to back this up, besides the fact that it does follow, for that part of the disease, it's following the rules that we know for ARDS. And I think we know how to support ARDS. We should use our knowledge in there. We know more about that than we know about the concussions that we're using for the early type of stage of the disease, whether it is hydroxychloroquine or any Kaletra or any other antiviral soup we're throwing at the patient. We know more about the ARDS portion of the disease.
Good point.
Great. Nitin, anything to add?
Yeah, I think that, we had a patient with acute pancreatitis who ended up going on ECMO, and he had significant inflammation, and I bet you his biomarkers were through the roof. We just never checked them, right? We've had somebody who had HLH, we had put on ECMO, who appeared to us first with pancreatitis, and his biomarkers were elevated. They did get checked. So it's just the utility of them is unclear. One way to figure out if they're useful is to study them. I think that that's what we're in the process of doing. And I think one of the best things that I heard during this is three of the four of us, one of our former mentors, Sergio Zanotti, said, don't run from science, embrace science in this moment.
Oh, you're saying so. I think we should run away. Great.
You are mentored by him. It's not it.
I was just trying to get involved in the conversation.
I just want to add something. It's this disease is not going to go away, so we're expecting it to stay here, not at for at least the next 18 months, 2 years, 36 months. I don't know how long. I can't predict the future, but I know it's not going to end in the summer. And I think knowing and understanding the science is very important. But to get to the science, I think I'm going to say that Haney has a point. You're going to have to try it. So, you've seen with SARS, they would throw the kitchen sink at those patients because they were desperate times and we don't know what to do with them. And at the end of the day, we are scientists, but we choose to do medicine. And our job is to treat the patient. So at some point, there will be a blur between what is scientifically proven and what you have to extrapolate from other disease, because we have no choice. The science is going to be behind us at some point, and the patient is not going to wait for you to really understand why COVID is going to act this way. Maybe in 5 years from now, we'll have more science. But being in the midst of it right now, I don't think we have a lot of luxury to say, I'm not trying it now. And that's part of the reason when I see those protocols coming in front of me, I was like, well, do I add to this the dance that's going to cure my patient? And in the back of my mind, I have this attitude, but I know that we have no choice. There's nothing else that has proven to work, and you have to try something. I don't know if you guys all agree with that, but I feel like it's hard to say, I'm not going to do this or that because I don't have hardcore science behind it, when you see a 17-year-old that might die if you don't try to do something. I just think it's very important not to ignore what we know. And what we know are the process of certain disease and how they progress, and treating them how we know. So proning, I would do proning 10 times over doing tocilizumab, right? If they made me choose, I'll go with proning. ECMO, I'll go with ECMO because those are supportive treatment that we know work in ARDS. But if you let me use both, and maybe vitamin C is not going to harm my patient, why not? if it's not going to harm? And that's the question. It's choosing the drug that's not going to harm your patient.
I think that's a really powerful point, because the patients aren't going to wait. They aren't going to wait.
Yeah, and
it's for you to be 100% sure about what you're doing.
For sure. And vaccines as well. We have to decide whether or not we're going to wait the typical waiting period for a clinical trial and efficacy, or are we going to curb things because, well, everyone knows what's happening with the economy and our social situation. And frankly, the numbers are increasing. So yeah, I think to everyone's point, we're going to have to start ramping some things up and not cutting corners is probably a bad use of words. We're just going to have to compromise what we're typically comfortable with for the greater good, as long as there's no harm in the things that we're doing.
Yeah, I have a slightly different point of view. Actually, but maybe it's just the same. I think that just assessing the harm is important, right? Like, I think the ventilator. The reason ECMO works is we know ventilators support people, but they hurt the lungs in the long term. Ventilators use lung injury. So the point is that trying to do things that have the least amount of harm. That point, do these meds have a lot of harm? With the Remdesivir trial, they changed the endpoint during the trial. Like, that doesn't seem like a good design. But I'm somewhat of a contrarian at baseline. The way I view, let's say, history, like recently there's been a documentary on The Last Dance, and I think the reason that Michael Jordan hates Isaiah is Isaiah helped form Jordan as to who he is, right? So here's what my point is. Jordan hates Isaiah because Isaiah was the last player to be able to beat him. And so, but that's a contrarian view of history. And that thread runs through my medical opinion.
Any way to work basketball into the conversation, specifically the Detroit Pistons, Dr. Nitin Puri will stop at nothing. All right. Well, on that optimistic note, I didn't want to end on the note of Raquel saying 36 more months of this, but I'm glad you turned it around somehow. But I just want to say thank you for taking the time to speak today. These are very, very helpful. The last updates was absolutely explosive on YouTube. So I think that people are looking to this as a source of guiding lights. And I'm so glad that we could provide another set of updates. And we'll be back next week again with some more faculty from Cooper giving us some insight in where we're at. And I hope next week we'll be in a better place. I know we will. But as always, if you have any questions about anything that was said, please comment in the links below. Subscribe to the channel for more updates. And we'll be bringing you more stuff as things go on. So thank you, Dr. Bartock, Dr. Nahra, Dr. Puri, for being with us today. And be safe out there.
Thanks, Annie.
Thank you. You take care.